Good morning, good afternoon, good evening. I'm Catherine Marshall speaking from Washington, D.C., and welcome all of you to this webinar on issues for vaccination and the religious dimensions for COVID, clearly. We are at a point now where we are recognizing a full year first for the pandemic and the transformations that it has made in our lives, as well as for the project that we launched at the very beginning from the Berkeley Center Joint Learning Initiative and the World Faiths Development Dialogue, really to understand and to assess, to track the religious responses to the COVID emergencies. We thought, given the tragic impact that this has had on so many lives, with 2.7 almost deaths worldwide, but an impact that is well in the billions of people, that we would take a brief moment of silence to recognize that. I think it's always important for us to recognize the impact, even though it is so different in different communities. The inequalities in the impact of COVID are so dramatic. But we are focusing in our project on the many dimensions, including hunger, the effect on children, the effect on conflict and violence. But now we are focusing quite sharply on the issues around the implementation of vaccination. We've held two events already, one in December and one in February, that focused again on the ethical issues, the vaccine equity, or as some people call it, vaccine apartheid, on the various efforts by religious communities to respond, both positively as models, but also to address people's concerns, which vary widely by community, by individual, different parts of the world. So today we have a number of people who are deeply involved in addressing the vaccination issues in different parts of the world. And we will be hearing from them both to give their sense of what are the priority issues as of now, as of today, but also looking forward. As is the case for all of our webinars, this webinar is recorded. The recording will be available afterwards, and we encourage you to raise your questions in the Q&A box. So with that, I'm going to turn to my colleague, partner very much in this venture, Olivia Wilkinson, who will give a short summary of some work that we've been doing to try to do what I was highlighting, which is to translate some of these broad principles and the ideals into a workable and doable function. So Olivia, over to you.
Thank you very much, Catherine. Yes, Olivia Wilkinson. I'm the Director of Research at the Joint Learning Initiative on Faith and Local Communities. I am going to share a few slides, but go through them very quickly. So we, Catherine and myself, have developed this quick analysis guide on faith and COVID vaccines. I don't expect you to read this very small writing, but this is just to show you what it looks like. And this is building from our project in the last year that Catherine's spoken about, but also very much building from experience, including experience of participating and working with UNICEF and World Vision, and as well as other faith actors and UN agencies that we might have on this call. I'm going to go through some of the questions, use some example questions, but first off, I just want to say, why have we produced a quick guide on faith and COVID vaccines? It's quick, because we wanted to make something that was useful right now. We know that people are making decisions right now. And we also wanted something that was short so that people could use it quickly, that we don't have a lot of time to read through multiple pages of reference guides so often. And so this is just 2 pages, one part for health and development professionals or actors, and the other side for faith actors. We've phrased the whole guide as questions. And why have we said questions rather than statements? Well, we thought that people need to analyze their context and not just receive generic advice. Questions point people towards finding context-specific answers. And this is meant to be just a start. They're questions to get people thinking about the process of faith and health and development partnerships for the COVID vaccines. So I'll go straight into the examples because I know we don't have too much time. So this first part is for health and development actors. The first question I'm going to pick out is this series of questions that we have under what. And I should say that in each side of the guide has a series of questions on what, who, where, and how. So on what, we've got a series of questions about assumptions behind vaccine hesitancy, the drivers of that hesitancy, and how other factors such as the political, social, cultural, and identity, gender, age, ethnicity, race, immigration, disability can feed into those drivers. And finally lead to questions about what are the religious aspects. And the reason why we put these questions there was to get people thinking about the complexity of these different drivers. All research and evidence we've seen has shown that we should not isolate or essentialize the religious aspect as the only part that's driving a hesitancy or a resistance. In almost every case, the religious aspect is deeply interwoven with some of these other aspects that we see in the questions. So then I'll go on to who. We have a question who about who are the acknowledged faith actors in the context and their dominance or perhaps lack of dominance of some actors and how the actors work together. And this is really just getting people to think about the dynamism of the faith community. All the different faith actors together are very dynamic. And we shouldn't assume as health and development professionals looking for faith partnerships that one actor guarantees us access to a whole group of people. We have to really understand the dynamics of who we're partnering with. So that's that question. And then in terms of how can we build on existing partnerships? It's a very basic point, but it's just the idea of we should not duplicate. We're not the first people to invent faith engagement or working with faith actors in vaccines. So we need to understand that there's going to be a lot of faith and health partnerships going before, and we can build on that previous investment, trust, and relationships. And then the other side of the coin is for faith actors. The what here is about what do the health and development organizations need to know that faith actors have that information and knowledge already, and what are the coordination and communication mechanisms that can be used to feed that information to health and development organizations. And the reason we're putting this here is asking faith actors to really be specific, know essentially how to get the attention of some of the health and development organizations, but know also how to coordinate and work within the existing systems. For example, is there someone that you work with or know that has previously worked for one of the health organizations and can give you tips about the structures and coordination systems that they have and how to get involved with those? In terms of where, we have very simply, is it possible to have a vaccination rollout or vaccination sites in a religious building that you operate or own? And we've seen examples of this. Many examples coming from the US, but also some other countries. It's not always going to be appropriate, of course, so it needs to be judged in each situation, but that is one of the main ways that faith actors can be involved. And then finally, a how question, which is for everyone. How can we find common ground in these partnerships and build relationships for the vaccine rollout that are fair and equitable? It's never too early or too late to start building these relationships, establishing common ground, and speaking of mutual interests and concerns and ways to move forward for successful collaboration between faith and health and development partners in the vaccine rollout. So I've whizzed through some of our questions. There are many more questions in the guide, and you have the link for the guide there. And I'll be happy to answer any questions after. Thanks.
Great. Thank you very much, Olivia. I think that the framework for this harks back to our discussion in the previous event, which the link to a summary of that is in the chat function. But what's distinctive about the rollout, as we call it, of vaccination in the places where we're seeing the rollout is that it is on the one hand, both very global. In other words, these basic principles of how things operate internationally and nationally with WHO, CDC, et cetera. But it's also very local. In other words, each locality has very distinctive features. And in fact, in the vaccine campaigns in the United States has substantial authority on all the three aspects, which are the equity, in other words, the priority list, the actual logistics of the way that it's actually rolled out, and then the messaging to try to achieve the kind of levels of vaccination that we all know are essential for us looking ahead. So the purpose of this matrix is very much to recognize the distinctive features of each situation. We're going to turn now to Katie Kraft and Andrea Kaufman, who are going to share the very brief time that we have given them, focusing on work that World Vision has done. World Vision, like the Berkeley Center, World Faith Development Dialogue, and JLI, drew a lot of lessons from the Ebola experience and from other pandemics. And so from very early on, we're convinced that the religious engagement would be a critical element in addressing the COVID crisis. And they have now produced a report which is both drawing on these findings, but also looking ahead. So I'm going to turn first to Katie Kraft, who will then pass to Andrea Kaufman.
Thanks, Catherine. You said half of what I wanted to say, so hopefully I will not waffle on too long. So yeah, we had the privilege, I think, of from the very beginning of this crisis of maintaining a very open dialogue with our faith partners and doing a series of different small research projects, data collection and analysis activities throughout the year to keep track of what they were doing and what they were contributing and what they were learning. So we were able to bring that together into this report. And so I'm just going to summarize some of the key learnings and then pass over to Andrea about what we're doing, about what we've learned. I think the starting point of this was the phrase infodemic, and WHO actually coined the phrase infodemic before they even called COVID a pandemic. And there is something really to this, that in this crisis, there is too much information going around. There are too many sources. There are too many people who call themselves experts, who are in fact experts with social media. Everybody has access to all the different information. And even though social and behavior best practices say that information is not actually what tends to drive behavior, there is also the principle that too much information can paralyze people. So we're in a situation where a lot of people just don't know what to do. And because they don't know what to do, they're inclined to do nothing. And that's where we really have seen our faith partners step into a gap and really play a strategic role in terms of helping people journey through this crisis, helping people process what they're hearing and make trustworthy decisions for themselves. So just some of the ways in which we found that faith leaders have been key collaborators in doing this. First is the process of navigating this infodemic, and we've worked really hard with faith leaders to make sure that they have access to good information and good guidance, that they are aware of what their government guidance in their respective countries are, and when they have that information, they do pass that on to people and help people think through what they're hearing and make decisions for themselves. So and we need to bear in mind, and this seems such an obvious thing, and yet sometimes we forget that faith leaders communicating really is what they do. They preach their Sunday or Friday or whatever day of the week sermons that it is. They message, they preach, they teach. It's very natural for them to communicate to people. And so when they are supporting best practices, what the medical professionals are saying, what government guidance are saying, which we try to help them to have access to that information, they can help transmit that information in a cohesive way, in a way that that gives people confidence to understand and feel like they can digest and work with the information. But also, and maybe even more importantly, faith leaders understand their communities. They know who they're working with. And kind of as has already been mentioned, is barriers to vaccine acceptance is very localized. It's very specific. Everybody has their own reasons for why they're making the decisions they're making or not making the decisions they're not making. And in different locations, we are finding through assessments globally that in different communities, different barriers are kind of coming to the fore. And faith leaders know what is going on in the hearts of their communities. They have the heartbeat of the people that they work with. And so they're sensitive to what those barriers might be. And so they can help bridge trust in helping people to communicate and dialogue through some of those barriers and talk through what concerns people might have. And then they also play an important networking role, and they can help bring people together and different stakeholders. They can collaborate with government people, with different community leaders, with different influencers, as well as, of course, NGOs like World Vision, and help people kind of come together cohesively in partnership and collaboration in order to help people get a more confident, cohesive sense of direction. But then the final piece, and perhaps the most important piece, is that they really do combine words with action. And it's been really, really encouraging and inspiring to hear stories of our faith partners who are going door to door and just asking people, do you have enough food to eat? Can I kind of go and get some help with filling in the education needs of your children? Or, okay, you're not working right now, what can we do to help you with work? And help really having a sensitivity to people's practical needs, and not just kind of pushing an agenda and saying you have to behave in a certain way, but also, of course, encouraging people to respect health and hygiene practices and have good information about the vaccine. And then finally, modeling behavior themselves. Again, words with actions. And if they think that the vaccine is the right thing to do, and they take the vaccine and say, look, this is my personal decision and this is why I've taken it, that can also be very meaningful. So those are just a high level. Some of the things that we've found have been some of the really important reasons why we see faith leaders as key collaborators in our work. And now on to Andrea to explain how that plays out in reality.
Great, thanks, Katie. What Katie's just described is really just the newest piece in a growing body of evidence that supports what many of us who've worked in the faith and development or humanitarian space have experienced in our work in communities for a long time. That faith leaders are essential partners trusted by their communities. And as Catherine pointed out, this is true across many circumstances, but we notice it incredibly acutely in public health crises, HIV, Zika, Ebola, and now COVID-19. So our job now, I think, as a global community is really to determine how we go from here. How are we addressing the current misinformation, disinformation, and mistrust challenges together? And also to increasingly develop effective and sustainable cross-sector partnerships that breed more effective two-way information flow, trust, and access for the most vulnerable. So in our report that Katie mentioned, we made a few recommendations that kind of will help us frame our work as we as we continue to partner more effectively. The first is kind of the blanket advocacy for fair and equitable distribution of vaccines and the assurance that they reach the most vulnerable. A second is to really ensure that we understand the local context and the key drivers and barriers through some sort of formative research that really aligns with the asking the key questions that Olivia presented earlier. And then we ensure that we include faith leaders and communities in the process. One way that World Vision is doing that is through a barrier analysis tool, which gives us information about perceived severity, risk, perceptions about social norms, perceptions about divine will, and an understanding of the faith leader role in that. And then finally, we know that faith leaders need to be engaged at every level, from understanding and interpreting the landscape, knowing what the barriers are, all the way through to design, implementation, and evaluation of vaccine plans. And again, one of the tools that World Vision has developed is the Channels of Hope COVID vaccine module that really seeks to meaningfully engage faith leaders and help them engage both with their congregations and communities, as well as with community health workers, policymakers, and other stakeholders. Thanks.
Great. Katie and Andrea have both highlighted the infodemic, which is the fact that we are dealing with something of a blizzard of information, and the importance of that is accentuated by the vital importance of trust, that people need to have confidence in their governments, but also in their religious and civil society institutions if we're going to get out of this crisis. But in addition to the infodemic, we also have many different organizations that are involved at every different level because of the heroic demands of the vaccination effort and the broader effort to address COVID. But one institution that has great importance that many of us know well, that has a long historic involvement with vaccination of children and of adults is UNICEF. And UNICEF is very much part of the coalitions that are addressing the COVID pandemic that also include, of course, the World Health Organization, the World Food Program, the G20, and many others. But here to give us some insights into, I think, the United Nations perspective, but the UNICEF perspective and the issues for cooperation is Deepa Risal Pokharal, who is very much involved in these issues on a day-to-day basis. So Deepa, over to you.
Thank you, Katie. So I'll talk about two things. One is the overall context of this COVID vaccine, and then I'll bring in the lens of how we have been partnering and continue to partner with faith-based organizations. So I think it would be useful for all of us to understand that this COVID-19 vaccine is quite different for communication people compared to what we've seen in the new vaccine introduction in the past. And some of the things which makes it a bit unique, but also challenging as communicators is the fact that we already heard from Katie and Andrea the infodemic, and it's very real and true that there's been too much information going on in the social media which influences people. The second thing is that this people have got mistrust in the sense that why is it that this vaccine has been produced in such a short period, though of course the rigor and the scientific evidence and all the due processes have been followed. The third thing is that the audience actually is quite different from what we are used to. We know that we've been vaccinating under 5 children, but in this case the age range is very wide, and the priority groups are quite different. For example, the health workers as not just communicators, but also recipients. We've got older adults with people with comorbidities, the essential workers. So it's quite different, which means that we need to understand what are the influencers, what are the communication channels that are there out there that we may not be aware of or we may not have actually known about in the past. And then the last thing, which is very, very important, is the fact that, yes, we do talk about vaccine hesitancy quite a bit for many reasons. It could be religious, it could be cultural, but there's this other facade in this thing about the management of expectations. So we are dealing with two, it's almost like a two-edged sword. One is the vaccine hesitancy. The other part is how do we actually explain to people that who want to come for vaccination that the vaccines are not enough because of supply constraints. So it's a very interesting and challenging world that we are facing right now. So in that context, I think there are some of the things that we see as being very, very important as we collaborate with religious leaders. And as you know, UNICEF actually works in over 190 countries, and we have got a long history of working with the faith-based organization at all levels, at the global level, at regional level, at national level, subnational, but most importantly at the community level, because that's where the conversations go on. So I would just like to start by saying that some of the things that we see as being very important through the demand working group, which is there at the global level, as Katie started when she was introducing me, there is a group which is working at the global level to support the country readiness and delivery, developing tools and guidelines. And our work, the subgroup that I am part of and have been engaged in, is the demand working group, which has produced a lot of tools and guidelines from how do we support the governments to do the planning, what are the things that you need to talk about for the health workers job aid, the training curriculums, the data bit, the quantitative and qualitative tools which could be used for quick and dirty rapid surveys, the misinformation field guide. So all these things have been developed at the global level, and that was actually one thing that I was asked to focus on. But then when I look at what is the intersection with the work that we do with the religious leaders, for example, the starting point is, of course, what is the science telling us? What is the data telling us? What is the evidence? That's one thing that we would really like to collaborate and have discussions with the religious leaders. The second part, some of the colleagues already mentioned, is then one part is the science. The second part is what is the concern and what are the fears that our communities are having, the drivers of vaccination, so to say. Are they hesitant because of the religious reason, or is it because of the safety concern, or is it that the services are too far away? So that part of the work, bringing in the science as well as the community's knowledge, is going to be very, very important as we collaborate with the faith-based organization. Then based on what is coming from the informal conversation, as well as it's not just social media, a lot of conversation are going on through the mainstream media. A lot of people at the community will come to religious leaders to ask about why is this being done in such and such a way, and why is it that we are getting certain vaccine and not this one. So, you know, a lot of questions do come to the faith-based leaders, and we've been fortunate that we've partnered very closely with the religious leaders. And then based on the conversation, what is the strategies that we really need to do to make sure that these misinformation, the disinformation is cleared? And I can think of no other influencer than the religious leaders at the community level as well as the national level to speak to their constituency so that they are convinced that the vaccines are for the greater good to protect the children, the population, in this case, the adult as well. And then the other thing that I also see as going to be quite an important thing is to bring in the different stakeholders at the community level, because when you have a mosque or a church, or it could be a religious gathering of the Hindus, or whatever actually the congregation that happens at the country level, that's where the influencers would be able to really make a mark on it. So I think when we look at the overall guidance and tools which has been developed at the global level, the way that it goes down to and flows into the country level is how do you adapt, how do you contextualize, translate it, use parts of it to make sure that, you know, people are understanding the key messages, the frequently asked questions that has been developed, or the key fact sheets that are there. It's all available in the WHO open site as well as the vaccine observatory. And then we would continue to partner with the religious leaders, whether it's through the interreligious faith councils at the global level or at the national level. And then we would continue engaging our partners and the collaboration and the long relationships that UNICEF has had enjoyed over the past years to continue the work. And I'm really glad to be among the like-minded people thinking about how we can all gather together to work on the well-being of the people. As you know, every religion teaches us that besides faith, if there's one thing which is common to all of us, it's the well-being of the population that we serve. I'll be happy to answer any questions. Thank you so much.
Well, thank you all. And we do have some questions coming in. I'm going to give you a minute to think about it, but I'm going to start with a question of my own, which is looking at the screen. We do have a rather unusual picture, which is very appropriate for March, which is International Women's Month. And of course, it is the meeting of the CSW this week. It's a focus. So I'm going to ask you, each of you, if you could reflect a little bit on any specific issues for women that you see coming out of the vaccination challenge. I'm going to first make just a general comment while you think about that, and then we'll turn to some of the questions that have been coming in on the chat function, and we encourage you to look at them. The focus of our project, the overall framework for this, and for many of you, this will be a very familiar reminder. It is the fact that despite many assumptions that religion is less important in the contemporary world, surveys suggest that more than 80%, even well over 80% of people have a religious affiliation. And even though, again, the data is mixed, faith leaders often have higher levels of trust by communities than pretty much any other group, government, police, NGOs, etc. So those are two major factors that religion is important and that this critical issue of trust is something that is particularly important for a campaign like the current vaccination campaign. The other issue is that we're very much aware that we need to address, and this is a part of the project, some infodemic misinformation. And one piece of misinformation is that there is some tension between science and religion, or between public health and religion. And as we have collected literally thousands of reports, pieces of information, it's very clear that there is strong compatibility between religious institutions and public health worldwide. Clearly, there are widely reported doubts in some areas, but in general, we have found that in terms of gatherings, practices, religious institutions have been leaders and have worked closely with WHO, CDC, UNICEF, et cetera, in trying to contend with the pandemic. So we're dealing with some misinformation to start with, and that's part of the spirit of what we're doing, is to try to make sure that we're putting the facts on the table and recognizing the enormous diversity of religious communities, which means that we will find an extraordinary range of information and understanding and wisdom, but also of misinformation. So let me, Olivia, I see you popping in and out, but can you address some of the questions around women, just so that we put a specific topic on the table?
Sure. Well, I'm happy to hear from the other speakers as well, but I'll just say very quickly, one of the things that we've mentioned in the analysis guide, and this is a question phrased slightly differently, but basically in both parts of the guide for faith actors and for health and development professionals, is how can you reach out to groups that are led by women within faith structures? So if we only engage with part of a faith structure, it might be overarchingly male, and we might be missing other forms of informal leadership, and the way that women's roles can come out within faith communities in other leadership positions. And so a question is, and this can also
we seem to have lost you temporarily. So maybe we can go to Katie or Andrea and see if we can come back.
Okay, it's a tough question because when we work with faith leaders, we are numerically working with men, although we did a survey of faith leader partners around last summer, and we did have quite a few female faith leaders participating who were every bit as active, if not more so, as their male counterparts. But I think one of the things that I hear from our female partners, and this might not be exactly where you want to take the question, but I'm going to take it there for a moment, is in their compassion for people's psychosocial needs in the sense of spirituality. And a lot of the female faith leader respondents in the survey talked about praying with people and spending time listening to their stories and hearing about their frustrations. And I think they have even male faith leaders to some extent obviously have some sensitivity for people's like family needs and the experience of isolation and some of the mental health concerns that emerge in there, and their presence and their compassion and their availability to listen and pray with people is it's not exactly a gendered thing, but I do think there are moments where women help draw our attention to that.
Yeah, there are a lot of interesting dimensions of the female impact of the crisis and the huge impact that it has had on women. But Deepa, do you want to comment on this, or shall we move on?
Yeah, I would just make one or two comments in a broad context, not specifically related to religion. So what data and evidence has showed us from different countries that we are working in is that, of course, we all know that the burden on women has been huge after COVID. And there are a couple of reasons for it. The schools are closed, so children are at school. So the primary caregivers are mothers and the women in the house. So actually the workload has increased. The gender-based violence in some cases, you would see from evidence that it's also in the right, increasing. And then interestingly, in some cases, actually, even the children actually, when you've got to look after the children all the time, the children also feel the brunt of it because they are not able to have this space which is given to them. So I think for the gender dimension, that's one effect of COVID-19 outbreaks, so to say. So women have definitely been on the receiving end more than anything else. The second part is now with the gender dimension, which we are also trying to work on through the COVID-19 vaccine, is there will be women with comorbidity. There will be adult women who may have special needs. So the important thing for us to identify is where are these women and where are these female population who should be eligible for vaccines. And this is particularly true when it's IDPs or the migrant populations or the people who are living in the conflict affected areas. These are likely to be missed out, and we shouldn't be missing it out from, if you look at it from the equity lens. So for the vaccination, we are trying to make sure that when countries are planning for vaccination rollout, that there should be a conscious effort to make sure that the planning includes these likely to be missed population, and then have the vaccination outreach in places where it should be going. It's not exactly linked with the religious leaders, but as you know, the religious leaders do have an influencing power. It may not be directly in many cases because they interact more with men, but then of course, eventually as families, they do get information on influencing the families. That's what I would actually say. Thanks.
Good. Well, let's turn to some of the questions. I'm going to try to read them. It's always hard to read these on the screen. But from Michael Chekim, he has another one, which we'll come back to. But this takes us into the broader realm. But I think it's worthwhile because everything is so interconnected, as we all know. So what is the role of faith communities in the non-medical secondary adversities of the COVID-19 pandemic, such as service workers who have new caregiving needs, such as caring for family members, whether elderly, young adults, or school children, and telework or go in person to work, restaurant or bus drivers, or even furloughed and need to feed their families. Now, I think that these were touched on in the earlier discussion in the sense that that there has been a major, though very, very difficult to map, outpouring of social protection responses of people addressing the crises in different ways. But would any of you like to jump in with any observations on how you see the linkages between what we're learning from this vaccination challenge and the broader COVID pandemic?
Hey, Catherine, this is Andre. I can jump in here. I think one of the things that we found in our report, even to date, is that faith leaders are already incredibly active across all of these realms. I mean, they were before COVID, and they have been throughout COVID. In terms of, the number one thing that faith leaders were doing in our surveys was sharing accurate information and addressing misinformation. But they were also, as Katie alluded to earlier, providing mental health and psychosocial support. They are seeing the most vulnerable and their needs, and they're jumping in, whether it's advocating for educational needs, whether it's addressing livelihoods, doing food distributions. This goes on and on and on. And so I think we'll see that continue, although the burdens are growing and growing and growing on these local faith communities, particularly in the most vulnerable communities. So it's a great opportunity to leverage even just their insider knowledge of where the vulnerabilities are, because they're already responding in effective ways.
I think it's a classic challenge because, of course, the sort of global effort is to mobilize unprecedented amounts of money, national effort, but also global. And how do you connect that to these very specific, interrelated, intricate needs at the community level? Let's take a question from Dave Robinson, who is also a partner in this project. So what is he asking? He's asking, what is experience to date for funding the faith leader training and empowerment during this pandemic? Late gaps and lack of resources to mobilize faith leaders in West Africa, the Ebola outbreak was a lesson. Do we have improvements to report? So I think this does go to our World Vision partners. So Katie, do you want to take that one?
I could jump in on that one too.
Okay.
I would say, Dave, it's baby steps to the goal, right? So we've seen some incremental improvement, really, in just everyone recognizing the essential nature of an integrated response that includes faith leaders from the beginning. Whether or not that has resulted in particular funding streams that we can access, perhaps not, but people are putting proposals together that include faith leaders from the beginning. So maybe the humanitarian industry has sort of recognized the importance, and we're seeing more integrated responses. But it's baby steps to the goal.
Olivia and I have both written a fair amount because we started this, as we said, with the inspiration of what we had learned from the Ebola crisis. And I think that our general sense is that a lot of the lessons about the religious engagement and its complexity have not been very well integrated into the public health profession, that there are still some barriers which are intellectual, but perhaps ideological and emotional, that have sort of contributed to a separation of church and state, we might say. So let me ask.
Catherine, can I just add a little something
Yeah.
there? When we did the research with faith leaders over last year, one thing that I heard repeatedly was that they had participated in some kind of a training, often a public health related training previously. And so they already had a relationship, in our case with World Vision. They already had an understanding of what their role was. And so it didn't actually take a whole lot to just give them a bit of health messaging on what was going on in COVID. It wasn't starting from scratch. And I was incredibly impressed to see how the ongoing relationship positioned World Vision so conveniently to step into that role so quickly.
Mm-hmm. Well, you may be a tiny bit more optimistic than I am, but we're working on it. Andrea.
Well, I was just going to say perhaps that there is a distinction, there's a contextual distinction. So when we're talking about the conversations that are happening at a national level or at a local community level, those relationships are there and they're easy. But when we're talking more about these global level conversations, we're reestablishing working groups that we established during Ebola and then shut down, right? And then now we're reopening them. And so I think that my thought at the beginning is to say, how do we establish these mechanisms and continue them? Because there are a lot of opportunities, not just in these major crises where we have to then build up the relationships at the global level. Let's keep them going.
Yeah. Well, I think on the positive side, first of all, the religious roles were recognized from very early on, though sometimes in a negative way because of some super spreader events that were linked to religious gatherings. So at least it was on the radar screen. And the World Health Organization and UNICEF and a number of other organizations have really reached out and tried in many different ways to engage religious actors. It's simply that it's a very complex landscape. So let me take another question. I'm not quite sure what what Michael Chikin's question is here, but maybe you will have inspiration. Maybe Deepa, maybe you can take this one. But how will this evening's YouTube live stream vaccination of DC area faith leaders with Dr. Anthony Fauci and National Health Association Director Francis Collins at DC's National Cathedral impact the COVID-19 infodemic for domestic and foreign audiences? I'm not sure whether he's suggesting that there's too much going on or whether this has particular importance. But do you have a response?
No, unfortunately, this is something very specific to US only. But
Yeah.
what we do listen to, because this comes from the science, is what is it that the evidence is telling us? And I think it has to be looked at it more from the way that the technical information is coming on, and from guided by that, how is it that we want to communicate to the countries and the communities and the faith-based organization. At this point, I think I don't have an opinion as such. We really need to analyze what is the guidance coming from.
I think both Dr. Fauci and Francis Collins have been very alert to the importance of the religious engagement. And I've followed some of their webinars, which have been, I think, very honest and very, very helpful. So I think we very much welcome that collaboration. And I see nothing but good coming out of the National Cathedral event, which is right. I can see the cathedral from my house. Now, Olivia, I don't know if you're back in yet, but let me try to take a question, which I think is really at the core of what we're trying to do. And Ghassam Abdallah has asked it several times, but it's how do we move from talking to practice? Now, clearly that's part of what we're trying to do with a webinar like this, with the Matrix, with partnerships, et cetera. But if you can communicate, why don't you see if you have anything to add?
Hi, I hope you can hear me, but I'm not going to put my video on. Okay. Yeah, no, thanks. And the question always is, how do we walk the talk? So I think this webinar is presenting some of the examples of work that's been going on, but of course, just the webinar format in itself is a lot of talking. So it might seem more like talk, but the talk is all just the front of what's actually happening behind the scenes. So if you think of us, you can see our heads on the screens. Well, actually everyone's legs like ducks below are going mad, and we're walking towards something that is a lot of collaboration between a lot of people, trying to coordinate, trying to make sure that we're not duplicating efforts too much. There's many different groups that people are on. So at global levels, for example, there's a group of faith-based organizations that will be meeting with UNICEF and WHO very soon to discuss coordination, for example. And we know that this is also happening nationally and even more locally, sometimes from city to city and town to town. So I think there is a lot of walking going on, walking off the talk. But of course, there are going to be some examples where we see places where that collaboration isn't happening. And perhaps people are talking about it and want to see it more, but they don't know how. And in that case, it is things, we hope examples like this webinar, other webinars, other tools that are going on that can help people overcome some of the barriers that are meaning that they can't walk the talk. And those barriers might be lack of existing relationships or deep mistrust between health and faith, for example, bad previous experiences that people have had that have made them very distrustful. And so there's a lot to overcome potentially. So I think, it's our constant question. We can't just talk, we have to put it into practice. But I do assure you that the people on this call, as well as many others, are doing that in locations around the world. Okay.
I would add that we're doing whatever we can identify and think of. So we welcome ideas and suggestions on what more we, as from where we sit, could do. There are two other sets of questions that I think, one is Dr. Ian Schenker is suggesting, I think rightly, that the experience of Israel is of special interest. And I think the previous webinar that we did, that we've summarized because there were so many important ideas that came out of it, suggest that the countries that are already deeply engaged in vaccination campaigns, that there is a great deal that we need to learn from those experiences. In an ideal world, perhaps this would be happening simultaneously all over the world, and that is the ethical approach that we would like to see. But the reality is that the vaccination campaigns are happening at very different paces. And so one of the key things that needs to happen is learning lessons. And we have touched on this during the discussion, but there are a couple of comments that relate to some of the specific religious questions, religious doubts about the specific COVID vaccines that have been developed, including specifically divisions within the Catholic Church. I think the question was actually posed, how do we feel? Well, I think we feel frustrated that there are divisions, but we also recognize that, that there will be many questions that people have. And some of the questions are completely understandable. In fact, all the questions are understandable and so on. And they call us, and I think this is very much emphasized in the Matrix, for example, to listen so that we are trying to hear and understand the doubts. There is evidence coming out that is suggesting that there are shifts, that as people gain knowledge, they are more willing to be vaccinated. And that the keys that make an enormous difference are personal experience and hearing from others. So the religiously linked objections seem to be less significant than the practical experience and how their community feels. So it's very local. So I think we need to build on that lesson. And within the Catholic Church, I think the Vatican guidance is very clear that the vaccination is both ethical and acceptable, but there clearly, as in every religious communities, are many different views. So that those are basically some of the issues. Now let's see. We had one other question. So this is from Kirsten Muth from the Joint Learning Initiative. As a truly global pandemic, many key faith actors have been very outspoken on the equity issues and access to vaccines to vulnerable populations, both in the global North and the global South. So what is the potential for more robust faith engagement to help address and mitigate these specific vulnerabilities? Who would like to address that? Deepa, do you want to take a shot at it? We have a very few minutes left, but this is obviously a critical issue for all of us. Mute. Mute. Mute.
Katie, I was going to ask you if you could just quickly summarize the question again.
The question basically is, what more could religious communities, but also us, because we're on the hotspot here, do on these real concerns about the equity, the inequities. I referred to it in the beginning with the rather brutal term of vaccine apartheid, or vaccine nationalism, which is the tendency of the wealthy countries to focus initially on their own populations.
Mm-hmm. Sometimes let me call myself a little bit of an insider who knows, because I've worked with the religious communities at the country level, but also not very much only doing that work. Sometimes I feel that there's not all the time, but the coordination could be much better, because we have the religious leaders, of course, doing an excellent work in all the countries that we've been doing. But then how do we intersect with the health system? Because this is about the outbreak, the health emergency that we are trying to. I think we also have to actually be forthcoming as all the partners who are working with the faith-based organization, but also the health system also needs to actually be much more forthcoming to bring in all the people together so that we could support each other, especially when you raise this issue of the equity. I think it's a very, very important thing, because what I see as a religious leader has been doing as an excellent work is to identify who these people are who are missed out, as I said in my presentation in the beginning also, and to be able to then connect them with the health system where the services are provided by the state, by the facility most of the time. I think that bridging the role between the communities and the health system is definitely something that I see as a role which we can pick up. Of course, it's easier said than done, because we are working more at the global level. Global level, probably coordination with different entities which are working on it. At the national level, at the community level, I think we have to be on the table, and then we have to connect people to the services. And this is something which not necessarily is happening everywhere, because the faith-based communities would be doing their own work and the health system goes and does their own thing. But how do we connect? How do we become the connector is something that we may probably reflect and try to do the best. But while I have the floor, I just want to say one thing. I think walking the talk, I wanted to actually pick on that. UNICEF, I can speak on behalf of UNICEF, but I also know that WHO has that partnership with religious leaders. More and more, we are working closely with the religious leaders. But when I think of a couple of things, like at the regional level, there has been conscious efforts to build the capacity of the interfaith religious leaders, not just one, but we have done some trainings. One was in Bhutan last year, and then we did our remote webinar after we started the COVID. Very prestigious leaders came and spoke about what they've been doing, and it was so inspiring to hear what they've been doing for the communities. But we also work very at the practical level, at the community level, engaging with them through the mosque announcement, having orientations with the religious leaders, listening to them, what they are saying. They've gone on videos, they've gone on radio and TV and spoken about what could be some of the things that the people can do. So I just wanted to say that increasingly we are working more and more with the religious leaders. Of course, there's always room for improvement and we need to continue. But I would think that we are very hopeful and we are in the right direction.
Olivia, I think we don't have time because we're at the very end. So Olivia, do you have 1 minute, and then we'll wind up?
I hope you can still hear me. I think all this to say that we are very aware that guidance documents are not the be all and end all of all this work, and that we need to keep working to make sure that people understand how to put this into practice. And we are willing and able to talk to people with any questions about how to put this into practice. So please get in touch. And yeah, I think that's it, actually. Back over to you, Catherine.
Okay, I'm just going to bring this to a close because we have a tradition of ending on time. And thank you to all of you. I think we are dealing with a challenge that is unprecedented, to try to vaccinate something in the order of 7 billion people very quickly. So we have the miracle of the development of the vaccine, but we now have the issue of the equitable allocation, the rollout in a logistic sense, and persuading people that this is safe and the right thing to do. And we are seeing at every level religious engagement in relation to other parts of society. So you have some of the world's most respected religious leaders speaking out on COVAX, on the vaccine equity issues, on the financial support, on debt relief, on all of the issues that are related to the crisis. But you also have in community after community across the world, you have communities coming together and responding. We all know the dangers that this can provoke division, but we are very hopeful that the sense of the common good, the common welfare, and the better angels of our personalities are coming out. So that, thank you very much to all of you for engaging, and we will be continuing the discussion.